Good afternoon, everybody, and welcome to all colleagues, friends, allies in the field of health workforce strengthening. My name is Corinne Hinlopen, and I am a health advocate and policy researcher at Wemos, an independent civil society organization based in Amsterdam, advocating for the right to health. And I'm really excited to moderate this Pillars of Health launch event to you this afternoon. And in order to make things run smoothly, let's first go through some already familiar house rules, I guess. The event is being recorded, and we will post the recording on our socials, just so that you are forewarned. You can use the chat function here in Zoom to briefly introduce yourself with name, organization, and country where you work, so that we all have an idea of who is attending. Please remember that the chat box is not for your questions. When the time comes to put your questions to the panelists, please use the Q&A function. We will be monitoring only the Q&A function to select some of those questions for discussion by the panel. Okay, a quick overview of the program for this afternoon. This afternoon is roughly divided into 3 parts. First, we will start with a quick introduction of why Wemos has started this Pillars of Health program on health worker migration and mobility in the context of health worker imbalances in Europe, why we are concerned with the situation, what's the issue, and what we think needs to be addressed. And we'll also share some of the findings from our research in selected countries to illustrate that situation. Secondly, we will have a panel discussion with our esteemed panelists, and I am really happy and proud to now quickly introduce all the 4 distinguished guests to you. And please bear with me a little bit, because all of these people have CVs the length of your underarm. Our guest of honor, Dr. Vitanez Andriokitis. Not only has he been a practicing cardiovascular surgeon for more than 20 years, he is also the co-author of the Constitution of the Republic of Lithuania, adopted in 1992. He's one of the founders of the Lithuanian Social Democratic Party and later on chairman of that party, member of Lithuanian Parliament for 6 terms. And during that time, he served as a chairman of the Committee on European Affairs, including during the accession to the EU in 2004. After his terms in Lithuanian Parliament, he was a Minister for Health in the Lithuanian government from 2012 to 2014. And from 2014 to 2019, he served as a European Commissioner for Health and Food Safety. And from 2020 onwards, he has been the Special Envoy of the WHO for universal health coverage for the European region and member of the Political Advisory Panel of the UHC 2030 movement. An author of multiple articles and books and of more than 140 legislative proposals and amendments on national and EU level, among them amendments to European treaties. So if we want legislative change, we know he's the guy to go to. And on top of all this, I can tell you that he's one of the most passionate supporters of further European health integration, which is exactly why we have invited him to this event. Dr. Andriukaitis, a warm welcome. It's an honor and privilege to have you.
Thank you.
Then on to first the 2 ladies, if you don't mind, Jim. Professor Milena Santric, a professor of Faculty of Medicine, University of Belgrade, where she is also deputy head of the chair of social medicine and the vice president of the Serbian Medical Society section for social medicine. Currently, she is vice chair of the European Burden of Disease Network and a steering board member of the UFA Health Workforce Research section. She was also very much involved as an expert on human resources for health in previous EU joint action on health workforce and planning, as well as on the CPME project, and an expert on migration and mobility in the EU's joint action on health equity Europe. In many national and international projects for the Serbian ministries, EC, WHO, World Bank, ECDC, etc., she was advisor or consultant dealing with health workforce planning and development, health management, policy and services provision, and her scientific work is reflected in numerous publications. On top of all that, she is one of the core members of our Pillars of Health project. And not only is she one of the friendliest persons I know, she is at the same time a very strict and critical researcher who will ask you all the difficult questions with the intention to make your research better, which is indispensable when you need good evidence for good advocacy. Welcome, Milena, to this afternoon. Sarada Das. Hi, Sarada. Sarada holds a BA in European Studies and Master of Laws in European Law from University of Maastricht. Sarada Das is the Deputy Secretary General of the Standing Committee of European Doctors, CPME. CPME represents national medical associations across Europe and is committed to contributing the medical profession's point of view to EU and European policymaking through proactive cooperation on a wide range of health and healthcare related issues. Sarada has been working with CPME since 2009 and assists the CPME membership in its activities relating to professional practice and ethics. She also coordinates the development of CPME positions into policy discussions and outreach action. It is in this capacity that I have come to know Sarada, and I've always been incredibly impressed by how she's always totally on top of what is happening in European politics and policies, always quick to respond to consultations and other opportunities for engagement, well-written, solid, clear positions, and a shining example for every health advocate, if you ask me. Thank you, Sarada, for being here with us. And I know that you're sort of a split personality today because you're also actually attending another workshop. Professor James Buchan. Hi, Jim. A senior fellow at the Health Foundation in London, adjunct professor of the WHO Collaborating Centre, University of Technology in Sydney, Australia, visiting professor at the School of Nursing, University of Edinburgh, Scotland, also the editor-in-chief of Human Resources for Health, the peer-reviewed journal affiliated with WHO. He has specialized in healthcare workforce policy throughout his career. His background includes periods working at a senior level in government in Scotland and Australia, and as a senior policy advisor for the Royal College of Nursing in the UK. He has also worked for WHO in Geneva and Copenhagen. In recent years, he has had extensive experience as a consultant on healthcare workforce policy and planning in Europe, the Americas, the Gulf, Asia, and the Pacific for governments as well as international agencies. And in our not even that many encounters with him, Jim has managed to build a reputation for being the man who knows everything there is to know about health worker recruitment and retention. And whatever you're talking about with him, he'll always come with a suggestion for a reference, an article, a report, a project. Thanks, Jim, for joining us today here for the panel. So that's our panel, a big virtual applause already. And then after the panel, thirdly and finally, this meeting will conclude with Aysel telling you a little bit more about what Pillars of Health will be doing, how we envision change to happen. And our hope is, of course, that we can manage to make you enthusiastic about the work we do and for you to join us in our efforts. So why Pillars of Health? As a matter of fact, some of the core partners in this project, we have worked together earlier on the same topic of health workforce, health worker migration and mobility in the European context. That project ended in 2016. We've kept in touch off and on, and at some point got together again because we observed that nothing much was improving. That access to healthcare and healthcare workers in Europe is still very imbalanced, and if anything, has gotten worse, thereby exacerbating health inequalities in Europe. And then COVID-19 happened. And the pandemic showed the world that without strong and resilient health systems, the most vulnerable get hit hardest. And that the health workforce is an indispensable part of the health system, not only to manage pandemics and its patient flows, but to build and carry those strong, resilient health systems. And hence the name of this initiative, Pillars of Health. And as in our previous project, we consider health worker migration and mobility as a contributor to health worker density imbalances. And in that sense, the European Union is unique because we have freedom of movement as an essential pillar of the European integration. And being able to move around as an individual and as a professional is a human right, and it brings lots of good things, but there are also important negative externalities to excessive and skewed migration flows that results in richer countries having more resources at their disposal and poorer countries even less, which is especially problematic when it regards professionals who deliver one of the most fundamental and basic public services needed for thriving societies, namely healthcare. International migration and mobility has drivers at both national level and European level, source country level, destination country level. Hence our idea to first start with some evidence building and a few striking country examples such as Romania, Germany, and France. And we added Serbia, not only because we have worked with Milena before, but because it's also a unique case as in being an accession country to the EU. Aysel will tell you more about it, and I'm sure that Milena will also touch upon that subject in the panel. But the role of Europe is equally important to address, as European legislation and policies have an impact on what happens at member state level. And somewhere in this complex policy force field, individual health workers are somehow trapped in the middle. And not to say that they are passive individuals, but only to stress that there are forces outside the individual's sphere of influence that shape the environment in which health workers, the individuals, take their decisions to move abroad or stay. So as I stated before, in our little core group, we did not see so much improvement, either at national level or the European level, and thus Pillars of Health was born, to activate, or if you will, reactivate civil society action and advocacy, because we really feel the need to put this problematic, unacceptable, and avoidable regional differences in healthcare coverage and health worker density back on the table of policymakers and decision makers, because of the cost of inaction is great, is huge, is enormous. At this point, please, I'd like to give the floor to Aysel, who will present a selection of our research findings. Aysel, floor is yours.
Yes, thank you very much, Corinne, for that. And I'm excited to be here and to see our distinguished panelists as well, and some familiar names in the attendee list as well. While I wait a second for the slides to come up on the screen, indeed, as Corinne has said, I'll be presenting some key highlights of the findings of the research that has been conducted by our colleagues in the countries that we're collaborating with so far. There's quite a lot to get through. We found some really interesting stuff, and I only have a limited time of 10 to 15 minutes, so I'll try to pick the most interesting aspects to share with you all. So on the next slide, you will see a map of the country reports that were conducted in. So today I'll present some information from Romania, Serbia, and Germany, and also on EU level, as Corinne has highlighted already. France is another project, another country that we're working with, and a report that will be available later in the year. So that is to come and more to find on our website. To let you know, in terms of the aim of the objectives of the research that we've done, it is really to understand the specific country context with regards to health workforce mobility and migration. That is informing our advocacy activities in these countries. We did this research by the following tools, such as the key informant interviews, desk research, and media analysis as well. Next, please. So I will start with Romania, as a country located in Eastern Europe and is known to be one of the source countries whereby a significant outmigration of health workers is observed. Predominantly, we try to look at the factors that influence this migration and to understand the situation, how can that be improved. You can see here defined some of the push factors that influence the health workers' migration decisions, as such, poor infrastructure as a result of underinvestment, low staffing levels, which can result in chronic fatigue and burnout, higher workload. For instance, also a mismatch between training and curriculum and job availabilities that matches those that are needed, and others that you can also see on the screen. There are also some pull factors that are important to consider as well, pulling them towards the destination country. Healthcare workers leave to also find higher status on their destinations. They feel more respected as well. There is better infrastructure and also more flexible schedules that are a big factor in determining where they want to work. Having said all of these factors and influences that make the decision, that influence the decisions of the healthcare workers, and despite all of this, the research found that the Romanian healthcare workers still wish to come back and practice in their countries. They often mention that they have a desire to return as they miss their families and they miss their culture. and they also want to give back to the country. The diaspora organizations of Romania are also quite active in development activities, especially when it comes to advancement of healthcare system, as they also do wish that one day they'll be back and be able to serve the healthcare systems in Romania as well. Next slide, please. So these key highlights are the drivers of our advocacy activities. They helped us to understand what is it that we can ask of the government or of the advocacy activities to improve the situation. Some of the key things that we come up with is, of course, to invest more, provide more financial resources, and invest into the infrastructure and the equipment in the facilities. Making more jobs available would lead to fewer patients per professional and a safer staffing levels as well. Implementing changes in education system to make it more practical in training, better interaction with patients, and also adjusting the number of graduates from the medical universities to correlate with places available in different specializations, for example, that would also meet the needs of the population. Focus on prevention, but also strengthening GP's role as a gatekeeper of the healthcare system is another ask that has been identified. And of course, solving the center and periphery discrepancies. To all of these, to address all of these, to achieve a change in that, there is a precondition that, of course, a political will is needed on ministries of health and other policy decision makers on the subject. Next slide, please. So to move on to Serbia as a country of our research, it's quite a different context. There are different challenges also because Serbia is an accession country. One thing to bear in mind is how the situation could change given their entry to EU single market and what can be done to prepare for such change. And that was really the key focus of the research of the team. What has been found is that there's actually at the moment no official health worker strategy or master plan that oversees the strategical direction of the strengthening development of the healthcare workforce. There is also limited data availability, both in public and private sectors. And although the public sector is the major employer of the healthcare workers in Serbia, there are only estimates about the total number of the full-time equivalent staff, and more exact data is needed. There is a health workforce policy, but the aim of this policy is actually to maintain the present coverage levels of the healthcare system and also to reverse the shortages of some specialists. And also there is, well, the data is limited and there's difficulty in understanding the situation of healthcare workers in the country. It's also even more difficult to understand the trends that are associated with the migrant healthcare workers as well. Well, some things to consider in this is that, well, firstly, there is no professional authority that collects the data to provide a precise set of indicators that can sort of monitor the annual net inflow and outflow of the health professionals. There has been some research that points out that there is a high intention to immigrate among the students and the professionals. And this is exacerbated also by the fact that there's a high unemployment rate in the healthcare sector. And what's more is that the WHO Global Code of Conduct that is not really reported on or implemented in Serbia, which is also part of the issues that can be seen with regards to data availability. Next slide, please. Thank you. So indeed, the key asks to solve some of the mentioned sort of findings would be that, of course, to first of all develop a resilient health worker strategy or a master plan that can help strengthen the healthcare workers of the country. Data availability should also be improved and start getting information on the trends and the information in the country. So one way to do that would be to establish a specific national authority that can collect and monitor this data. And of course, as the evidence will build or the data is collected, it should be analyzed and then become available both to a set of key stakeholders of interest, but also active civil society to really better understand and share knowledge and ensure strengthened advocacy on this. And of course, to fully implement the WHO Code of Conduct, Code of Practice, apologies, on the international recruitment of health personnel. And yet again, with all of these things, you have to have a political will in place to make them happen. Next slide, please. So to move on to Germany as a European giant and also well known to be one of the top destination countries in EU for migrant healthcare workers. And despite the fact is the country is also suffering from a nursing crisis, which is predicted to get even worse in the coming 10 to 20 years. And some estimates are that there will be around 200,000 to 300,000 additional nurses needed by 2035. This is made worse by the reforms in the German healthcare sector that led to cost-saving pressure on the nursing sector. As a result, what happened, there was a decreasing number of hospital nurses, and also the working conditions of them deteriorated as well. There was higher workloads, time pressure, lower wages, and caused job dissatisfaction, and then even further dropout and quitting of the jobs, even before the COVID-19 pandemic. And the number of immigrants migrant healthcare workers in Germany is at a point of concern, particularly when it comes to those that come from the smaller source countries. The recruitment for these often happens via official channels, such as bilateral agreements with these certain countries, but also private recruitment agencies. The extent of it goes as far as to, for example, 2% of all Bosnia and Herzegovina nurses actually work in one single German hospital. And also, well, actually, on the contrary to that, there's also retaliation to these practices that has been observed as well. For instance, Serbia is an example whereby they had a bilateral agreement with Germany that ended in 2019 to ensure that excessive outmigration does not damage the health system further. And well, in addition to that, also to highlight that since 2013, the share of the foreign nurses in the German nursing workforce increased from 5.8% up to 11%, and to a total of around 200,000 non-German nurses employed in the healthcare system right now. And you can also see some figures on the slide to project in terms of the relativity of that, well, majority being from Western Balkans and relatively to the total nursing workforce in those countries as well. It's quite significant. But these numbers don't even consider the 24/11 nursing carers that live in people's houses. So if you consider those as well, and the numbers from that get even worse, there are around 300,000 up to 700,000 migrant women from Eastern Europe that work in German private homes, and those often also have nursing diplomas. And but the information on that is quite limited as well. Next, please. So there is also a lot to be done in Germany, but some of the key asks that to highlight here is that, well, first and foremost, it is to, in order to prevent the current trend and also to increase the number of domestic nurses in Germany, it's clearly needs to be increased attractiveness for the profession. There was already quite a number of initiatives that took place over the years, but more needs to be done on this. And the trend on the shrinking nursing numbers from domestic sources is yet to be reverted. Secondly, it's important to also regulate the private recruitment agencies to better protect also the legal rights of migrant nurses and do no harm. And the last ask is that to improve data availability on the 24-hour live-in carers, as there is a huge sector, as mentioned earlier, on this, and data regarding the scope, the size, and also the qualifications of the workforce that work in those settings is not available clearly. So that needs to be regulated as well, and share some light into that. And of course, as with others, it's important to highlight that we need to have a political will to do any of these. Next slide, please. So moving to EU level, and also touching upon what some of the things Corinne has mentioned in the early introduction. Well, the COVID-19 pandemic put shortages of healthcare into the spotlight, but it is by no means a new challenge for healthcare systems in Europe. In, for example, 2021 edition of the State of Health of EU country health profiles, health workforce shortages are reported as a key health system challenge in 15 countries. If you look at the map, also what you'll see, which is from the same report, you will see some key differences between the countries. Those highlighted in a lighter color have lower densities of doctors, and there are some variations are quite dramatic. The numbers, for instance, of practicing doctors in Poland is 2 factor less than those in Austria. And these geographic discrepancies do not help the already compromised healthcare systems, And although the differences in the physician densities are reflected by a number of factors, the variation is actually explained to a large extent by differing intensities of staff shortages affected the national healthcare systems across Europe. This is one of the drivers that have been identified to motivate healthcare workers to move to greener pastures, so to speak, and in turn compromises the access to skilled, motivated healthcare workers for all citizens, particularly of the less affluent countries or those in regions of less density of healthcare workers. Additionally, what we found through our research and during key informant interviews that we kept hearing that it is not really so much the magnitude of the mobility, but the constant outflow that creates a further problem. There needs to be a trade-off between the efficiency of the market and equity. And it's the asymmetry that you also see from east to west, from poor to rich, that is part of the problem as well. Next slide, please. And also going back to what Corinne mentioned in the introduction, believe that health workers' mobility must be addressed at three interlinked levels. You can see here the source countries, EU destination countries. Each of these are affected differently by excessive health workforce migration. And a change on each level is needed to achieve equal access for health workers for all citizens. And ultimately, it is the health workers that need to be protected and are given the adequate opportunities to develop professionally with equal opportunities to their colleagues across the EU. They are really the pillars and the core of the resilient healthcare system, and they must be protected. So using this framework, what we believe is that a change is necessary on each level, but also and only if a clear synergy among all actors is sustained in order to achieve meaningful improvement of the situation. EU, that comprises of member states, which are both the source and destination countries, and without responsible sort of an active data collection from the member states, any proposed indicators from EU will not be sustained either. Also, without adequate investment of resources that would address and mitigate the push and pull factors that we've discussed earlier of the migrating healthcare workers, there'll be no sustained retention of healthcare workers in the source countries. And also, likewise, without a clear self-sufficiency strategies, international recruitment will continue to be easy and quick way to fill the vacancies in the destination countries. What must be said is that EU is already doing quite a lot to strengthen the health workforce of the member states. There are plenty of initiatives that have been completed and more are ongoing. For example, also the latest one being the activities of the Health Workforce Project Cluster that focuses on medical deserts, task shifting, and mental health of healthcare workers. But what else needs to be known is it's the understanding of the actual cost of inaction. We believe that addressing this issue of implementation is paramount, and for the betterment of our union and the maintenance of our principles of solidarity and prosperity, which can be undermined if there's no action to address this imbalance of health workers' mobility across the single market. And again, having the political will is a key to this action. And what I also highlight is that, or recognize that these asks are not final, so to speak, and it's not the extent of them. That's why we need to join forces with other actors to develop this further, to contextualize them and make them sustainable. Lastly, before I move on to the last few slides, is that I want to highlight that all of these policy changes and asks have to be considered through a gender lens. That's really important to also highlight the need for gender aggregated data and to ensure that gender research is considered to all of this, because as we know, healthcare and health professions are gendered. And it's an important factor that also motivates and drives certain healthcare workers to migrate and move. Next slide, please. Yes, so what I would like to end this presentation on are just a few quotes from healthcare workers that were keen to share their stories, really to showcase why they migrated and if they see a way back. Also, just to give you a human side of the policy talk. The health is political, and the policy is about people at the end. So I'll start with Claudie, who lived abroad and has now returned back to Romania. Claudie's story is that the country needs the returnees to share the experience and to help others grow. She sees improvement in the working conditions. That is a good sign. And also there's a strong desire to give back to the country, the feeling of being needed. as she put it. Next slide, please. Dana's story, that you can see also her picture here, she left to pursue her passion in psychology, which at the time wasn't an option in Romania. She still lives abroad in the Netherlands and she practices her profession, but is also considering going back since the country is catching up in her field. And I would like the last quote on the next slide is from Flavius, who is a young trainee cardiologist that left to find better education system that works for him and is happy to be in an international environment. One of the drivers that he shared with us was that there is a corruption and lower salaries. And as a young professional, he would be happy to stay where he is based on his experience so far. And with these stories, the last slide is just to say, yeah, I would like to conclude the presentation and say thank you very much for listening and for your attention.
Thank you, Aysel. Thank you. A wealth of information indeed, and I know that you've only scratched the surface of what we have been investigating with the help of our partners, among whom, of course, Milena, who is here on the panel. I would like to kick off the panel discussion, as a matter of fact, and I would like to start with Dr. Andriukaitis. Dr. Andriukaitis, if you would like to unmute yourself. I know that you share our concern about the current situation regarding universal health coverage and disparities in health worker density. And from your extensive experience working at European level, could you give us your perspective on how serious this situation is?
Situation is not only serious, but very serious. Please keep in mind that now we are facing a lot of crises, including war in Ukraine, refugee crisis, post-COVID situation, of course, all issues related to COVID. And of course, as you know, we lost a lot of attractive people who decided to work as nurses. And after the beginning of COVID, it was so difficult to work, and working conditions were very, very difficult. And now the situation with nurses is very worrying. As you know, countries in the beginning of COVID, they started to ask nurses to work extra hours, canceling leave, changing staffing recruitment, changing contracting from part-time to full-time. It creates a lot of challenges to those who works in especially in intensive care. And of course, also speaking about situation in general, globally, we have very difficult picture. Now we need to have more than 18 million nurses and doctors additionally, because lack of resources. And if you look at the European continent, when we speak about universal health coverage, we have no chance to guarantee universal health coverage if we have nothing on the ground. And also very important to know that when you see differences within countries and between countries, you can find very strange and very complicated situation. But what is also important, healthcare workforce, discussions at EU level are not so high on the agenda because of it is national competence. And of course, now we are speaking between us, between public health specialists, between medical communities and so on. But if you look at a broader picture, how many times national parliaments are debating issues related to healthcare workforce shortages, planning, recruitment, retainment, attractiveness of healthcare, working places, so you can find only episodical situation. But also, please keep in mind, we see big constitutional asymmetry. A Lisbon Treaty, which enshrined limits of legal limits working in the Commission, the Lisbon Treaty is absolutely, very weak legal instrument if you are speaking about possibilities to use much more activities at EU level, helping member states to address healthcare worker shortages on the ground. Why? Because health is ancillary issue in Lisbon Treaty. And only few, public health issues were enshrined into Lisbon Treaty. And mainly issues, yes, it is national competence. Mm-hmm. And on one hand, you see big contradiction. We have one internal market between all 27 member states, and of course also including accessing countries. In another hand, we have national competences and national, decisions related to healthcare workforce recruitment, retainment, planning, and so on and so on. Yeah. And free movement creates really challenging issues with possibilities to deliver public goods. Yeah. Because health is constitutional right, and public goods in health, they should be delivered, doesn't matter where you are, in small village or in big city or in a rich country or in less economically developed country. And you see that it is out of radars debating those issues and discussing how can we combine free movement with possibilities to guarantee access to primary, especially the primary health care.
Yes, exactly. That's one of the cruxes of the problem, actually. And I think it's a nice segue into a question that I have for Sarada, because Sarada, your constituency, and if you would already unmute yourself before you start talking. Your constituency, of course, is working day and night to provide the best quality care for their patients to ensure this universal health coverage. When you hear Dr. Andriukaitis speak about these big European issues and the right to move around for professional or individual purposes, and they are the providers of healthcare, how do they perceive this problem, and what should be done about it? What can be done about it?
Well, thank you very much. Now, I've already heard a lot today that I can agree with, and I think that very much reflects the experiences also of our members, which are the national medical associations across Europe. And yeah, maybe to start, one of the words which caught my eye, because this is also what we sort of departed from, is the word attractiveness. I think there's really the worry that the profession, the medical profession, is no longer an attractive career to go into or to stay into. And this, of course, causes a great problem for the healthcare systems, for patients, for the whole society. So from our side, we're really looking at how does the medical profession stay attractive. And here, of course, we've already indeed addressed this issue of migration, and we very much support migration. And it is, as I said, a personal right, a professional right. And I think in your stories, we saw the benefits of knowledge transfer, of learning from one system and integrating it in another. So that is exactly, I think, what needs to be maintained. But of course, we also see the negative dimensions of migration, where professionals are forced to move out of their profession due to unsafe working conditions at home or a lack of career opportunities. And on the other hand, we see in some countries still tendencies to look beyond their own health system to fill shortages rather than make sure that they can work towards self-sufficiency. So from our side also, we looked at what can be done. And at one hand, at the national level, we said there is a strong national dimension of organizing healthcare, but also education of professions. We really see that there is a lot that can be done just to reach the level which is already afforded by law, for example, in working conditions, working time, but also to make available time and resources for professionals to follow training, to engage in research. And also one point I saw on your slides, which I thought was very interesting because it also came up in our discussions, this issue of transparency of filling positions in hospitals, for example, which is very important, and also making jobs available. This is also something that's been raised, that there are paradox situations where shortages and unemployment coexist. So it's very important to tackle this. But then also we believe, and this is something really that the pandemic has brought a shift in our thinking, and as a CPME, we believe that there is also more action that can be taken at EU level. And we know that the EU has already, of course, we mentioned the free movement, but also for working time, for example, legislation. But we also think that there can now, in the whole scope of the health union, action can be taken on improving, first of all, data collection to know capacities of national health systems, but also for the Commission to take proactive action on issuing benchmark recommendations for resources. So for example, including workforce, but also other facilities. And I think we saw in the pandemic now that upscaling systems was difficult in many countries, often not even so much for the lack of equipment, but for the lack of workforce to operate, for example, intensive care units. And we think that it's really, despite the subsidiarity which remains, it is really time for there to be concrete recommendations, for example, of a ratio of workforce per population for GSM to achieve universal healthcare, but especially also to build surge capacities. So I was very pleased to see many of the points raised in the presentation, because they very much reflect these thoughts. Absolutely.
Yes, that's good. That's good. Good to hear. Yeah, that's it's interesting, because if I can turn to you, Jim, Sarada is mentioning a number of measures that can be taken to improve the attractiveness of a profession, which undoubtedly is, are good measures to take to improve recruitment and retention. There is a lot known already about evidence-based policy options to strengthen health workforces and health workforce management, from health worker recruitment and retention to planning and forecasting. What do you see? What is keeping policymakers, or decision makers, I should say, from implementing them?
The big question. I think I would give 3 short responses, and the first one would be, it's Friday afternoon, so let's start by being kind to policymakers. They're busy people, they've got competing priorities, they've probably not got enough resources, they are trying to begin to deal with the living and working with COVID and beyond COVID. So I think we have to recognize that their agenda is very crowded. And if we are to influence their agenda, we need to ensure that the work that's being undertaken, the research, the evidence generation, is provided in a way that targets them effectively. So it's got to be about solutions, it's got to be about what happens if you don't implement the solutions in terms of population health deterioration, costs on the economy, for example. So I think we can ensure that the messages are well framed. And I think Wemos is very good at doing that, but I would not point to all other research institutions investing enough in getting the messages through. So that's being kind to policymakers. The second response, I'm being less kind to policymakers. I think the question is, what do they do with what they know? And I think when we look there and we look at health workforce challenges, be they retention or planning or new recruitment, many of the solutions are relatively long-term in terms of securing significant benefits. And in many countries, there is a relatively short perspective from governments and policymakers, because they are maybe looking beyond the next election, but not much beyond that. So if it's taking 10 years plus to train a new doctor, that's somewhat in the distance from their perspective. So we need to recognize that in the post-COVID landscape, the influences we can put on them need to ensure that the ideas of a longer term perspective need to be kept in mind. And secondly, linked to that, there is a tendency for governments and policymakers to pick on a magic bullet solution that's going to solve it all quickly. In health workforce, that rarely, if ever, happens. We need to be recognizing that we coordinate and implement a bundle of policies. For example, if we're looking at retention, it's not just about pay, it's about flexible hours. It's about access to step-down facilities if there's COVID burnout. The third point I think I would make is when we talk about policymakers is who are they? Who are the policymakers? And I strongly agree with the points that you've already made, that we need to ensure that the policy dialogue on these issues is not only led by ministries of health, because the reality is that health is labor intensive. Ministries of finance need to be at the table for this dialogue because they are the ones who fund, but also will recognize the costs of not funding effectively the workforce. Civil society and education stakeholders as well need to be there. So that's perhaps an overcomplicated response, but I think it's a complicated terrain. And if we think simple, we won't get very far.
Thank you, Jim. It is complex, but you've managed to tone it down to 3 very overseeable pieces of advice also. Thank you. We can take that also up in the coalition to put into practice. Well, if you're talking about long-term, forward-looking strategies, and I would like to turn to Milena here. I remember that when we first started our collaboration, our Romanian colleagues told you about the thousands of doctors and nurses that they lost to other European countries upon entering the EU, and asking you if Serbia really is sure to want to enter the common labour market. Can you share with us how your government is anticipating entering the EU free labour market and the potential impact of that on the Serbian health workforce?
Thank you so much, Corinne. So first of all, I would like to emphasize that I really like what has been said so far. First of all, yes, Serbia is a unique case, and we like to think about us as a unique country.
Of course.
But also, I like the point made that we have a unique health labor market in the European Union. So this idea that a strong and resilient health and care workers have been and will be an essential pillar of the health system in the future as well. In fact, are saying that the strategic monitoring and positioning at the EU health labor market are necessary activities for every participating country, including Serbia. And our government rhetoric is focused on the benefits we will get from improving our legislation and regulation of the health labor market, considering the dynamics of the neighboring and partner countries with whom we have a strong relationship so far, including Germany. The starting point in policy development is, of course, to understand the current progress in the EU integration of Serbia and the trends we have in our internal market and external health labor market. In that regard, let me say that Serbia is a candidate country for a decade. And since the start of accession negotiations in January 2014, only 12 out of 35 chapters have been opened so far. But the negotiation chapters we are mostly interested in regarding these migration issues are 2, 19, and 28. And these are still not open. These are chapters about the freedom of movement for workers and employment social policy, the chapter of social policy and employment, and the consumer and health protection chapters. The course of negotiation in future will affect, of course, further normative and institutional harmonization with acquis of the European Union. So in regard to labor migration trends in Serbia, let me tell you more about it. We can highlight these trends from the 3 perspectives, including situation perspective, that is migration and health labor market differences, the mechanism perspective, that is regulation and incentives we have, and likely impacts, that is opportunities and trends we face once we get into the EU health labor market. But all of these require more time to explain. So in brief, migrations are going to be central demographic issue in Serbia in the next period, not only health workforce issue. So that implies that we have a governmental responsibility here. The number of foreigners who have been granted a temporary working permit is significantly higher than the number of permanent working permits issued in Serbia. About 30 times higher was in 2017. About in the same time, the number of Serbian citizens that left the country, indicated as newcomers in some of the EU countries, is about 0.2%, but this number is increasing. And numerous Serbian citizens are just seasonal workers in EU countries because of the high demand of EU labor market and because of the requirements for long-term residence in the EU are still demanding for us. The main reasons for leaving Serbia are better living, working, and employment conditions, and these are reasons almost the same for health workers specifically. We know that approximately 15% of employees in the state network of healthcare institutions is seeking to change the job to work abroad in the next 5 years, and this number is growing since 2014. From our study, we also know that the profile of potential health worker emigrant is medical doctor, nurse, young, and employed in inpatient sector, so not unemployed health workers. In addition, our previous research showed that a significant number of medical students and specialists, approximately 2/3 of our study participants, intend to leave the country as soon as they complete their studies. And the longitudinal Serbian attitude toward European integration indicated that pro-EU stance has improved over time, and the stronger the international initiative of EU actors, the greater is the share of supporters of EU integration among medical students in Belgrade University. However, a better understanding of the comparative quality of healthcare in EU and non-EU countries and labor market health issues remains the goal of our teaching and communication efforts. That is what we know from our research. And we have more research to show that the main differences between the health labor market situation in Serbia in comparison to EU member states include that there is a mismatch between the supply and demand of physicians and nurses and care workers in Serbia. What we found is in 2028, only 60% of unemployed workers were needed based on data on vacancies. And don't be surprised when I tell you that we have in National Employment Services total of 13,332 unemployed physicians, nurses, and care workers, out of which the majority were females, nurses and care workers, and long-term unemployed persons.
Which goes to show also the gender dimension of the health workforce and how it affects also unemployment rates and who is affected by it. If I may, Milena, because I sense a theme here also on the basis of what Jim said, an additional question to Sarada actually, because many actors are needed to improve situations regarding health workforce strengthening. And from the health systems and health workforce point of view, our Wemos's, maybe the coalition's natural inclination is to work with DG Santé and to influence health policies. But since many of the recommendations on health workforce strengthening actually have to do with creating better working conditions, safe and secure working place, adequate salaries, provisions for lifelong learning, should we as a movement not rather focus on, for example, DG employment or the pillars of the European pillar of social rights instead of health policies? How would you, I see Jim nodding, I see Vytenis nodding, but Sarada, you first, please.
You will also see me nodding. Absolutely.
Okay.
No, I think, and this is what we're trying to do. This is absolutely an issue which also affects employment. We are also talking to DG ECFIN, who deal with the European semester, who deal with, which is an economic program. And indeed, I think James Buchan also mentioned finance. So we're hoping that some of these tools will actually give the health ministries better arguments to make towards their treasuries that they need resources. And I think it is absolutely necessary to do this as a sort of cross-government approach, because we saw the effects of bad health or lack of health system also take effect across government and across society.
Yeah, you're absolutely right. Yeah, this is something that we, I think, as a coalition will have to learn more about. As I said, our natural inclination is to work with health policies, but we should look broader, I guess. Yeah, I will invite, in the meantime, the participants to put their questions to the panelists in the Q&A function. But is there among the panelists the need to want to respond to any of the other panelists, actually?
If I may.
Yes, please.
Colleagues, I fully agree with James when James mentioned that we need to have long-standing policies. We need to have long-standing monitoring. We need to understand complexity and multi-sectorial issue when we are speaking about healthcare workforce shortages and other issues. It covers Ministry of Education, it covers Ministries of Finance, it covers Ministry of Social Affairs, it covers Ministry of Interior, because, as you know, local municipalities, regional situations are very different one, and local communities also are playing a role, and we need to understand situation, how can we guarantee and provide healthcare for those who are staying in rural areas and remote areas, and of course also we need to understand that it is a permanent situation to monitor, to exchange data, and to have reliable data in the whole EU. And I fully agree that we need to have some, like to say, some pan-European also mechanism which can allow us to combine national efforts, local efforts, and European efforts, finding solutions. How can we address, how can we, maintain free movement, but also how can we address issues with people needs on the ground? Believe me that if we have shortages on the ground, people are worried about European Union future because they are voting in favor of radicals, they do not like European project at all in those abandoned regions. It's very dangerous for our democracy. It's very dangerous for the European Union project. We need to understand that we need to deliver public goods and health closer to people. Leaving no one behind is empty slogan. If you have no chance, really, to leave no one behind. That is a problem. It's not only using digital tools. We need to understand how can we keep enough for healthcare workforce on the ground.
Yeah, we were talking about the cost of inaction before. I hear you say something like it's about the European project that's at stake. It's about those left behind who will turn their backs on the European project, so to speak. Yeah, I like that. Participants, please do not refrain from putting your questions to the panel. But again, are there panelists who want to respond to each other? I have some spare questions or reserve questions also on my piece of paper, of course, but Jim, please.
Thank you. I think we're getting into really interesting policy territory here, and I thought I'd just make a contribution. Unfortunately, the UK is not in the EU anymore, but we are just seeing a record ever high number of nurses being recruited to the UK from other countries. And part of that very rapid growth has been accompanied by a very significant drop in recruitment from within the EU and a very big increase in recruiting nurses from outside the EU, particularly India, Philippines, and Nigeria. So I think we've got to recognize that we're not in the free mobility zone anymore. And I think we've got to recognize that free mobility is not the cause of shortages. It's an enabler for individuals to move, and it may accentuate existing shortages. But the case study from the UK is that you don't need to be in the EU if you're a high-income country to be able to go other places. And I know Germany, for example, is already recruiting from outside the EU as well. I put up on the chat a link to a report that I was involved in publishing earlier this year, which looked at nurse recruitment and retention globally. And it's very clear that the pandemic has rapidly increased demand for nurses, partly because there's been a growth in demand, partly because the supply has been compromised.
Yeah.
And it's likely that many older nurses will either resign or retire over the next 2 or 3 years. So to the extent there is a problem, it's going to get more pronounced.
Yeah.
And within the EU countries, I think there is scope to look at better coordination. But I think we've all got to accept that the underlying issue is that there are not enough nurses.
Yeah.
And that requires improvement in retention, but also trying to increase supply.
Yeah, the numbers.
Thanks. Yeah.
Yeah, not just the distribution, but to just get the numbers
We need
up.
both.
Yeah.
And particularly for population access, distribution is going to be critical.
Yeah, absolutely. Yeah, that report was a great reading material, actually. The emphasis that it also put on self-reliance of when it comes to nurses. It was an ICN report, of course, but it holds the same holds true for doctors and all other cadres, if you ask me.
Yeah.
But that's I think that's a key issue: self-reliance. How can we make that happen? There is a question in the Q&A function by Annette Schrouwen. Hi, Annette, good to see you here. And her question is talking about migration. What about the European Commission's plan to boost legal migration from outside the EU? How does that relate to the internal free movement issues? Who would like to take that question? If I can rephrase it, but I'm not sure if I will do justice to Annette's question then. Vytenis, are you raising your hand?
Yes. First of all, I can tell you that the Commission has no plans to do something, because the Commission works in strong legal limits. Commission can provide propose joint actions to member states to work because recruitment is absolutely national competence at the moment, because Lisbon Treaty do not allow to act at Commission level. As you know, we have no shared competencies in health and public health. Only Commission can facilitate, coordinate, and supplement or cooperate if member states can express their willingness to do it. And the one instrument is joint actions. But from one joint action to another joint action, the Commission goes, and those steps are very slow, and not big appetite from member states to join into actions. Some joint actions, 14 member states, but not, for example, 20, 24 or 26. And of course, and as you know, health never was high on the European Union policy, on the radars of European Union. In 2017, we presented a white paper on the future of Europe. 5 scenarios were presented in 2017. And no one scenario mentioned health as a problem. And it was very, peripheral issue, keeping in mind that it's okay, it is national competence. Don't touch it. Okay, free movement, yes. And also not all professions were under directive of professional regulations. Public health professionals also have their exceptions, and it's a very complex one. The Commission was never involved in debates about possibility to discuss issues about planning or
Yeah, well, there were some noises coming from Brussels, so to speak, about boosting legal migration from outside the EU. And I agree with Annette that in the Netherlands that it kicked up a lot of dust on the immigration discussion, which is always very precarious in the Netherlands. But yeah, thank you for your clarification. There's another interesting question in the chat, actually, or in the Q&A box, I should say, by Heino Guldeman. He's the one who actually did our German case study. And he says, why are we so shy about asking the EU to govern health workforce migration? According to the principle of subsidiarity, each problem needs to be governed on the lowest possible level. In case of cross-border migration, this logically needs to be a supranational level, which is the EU. This is an interesting point of view. Who would like to comment on that? Maybe Sarada. I mean, if you, from your constituency consists of medical associations, who then consists of medical doctors, how would you reflect on this?
I would tend to agree that I think there is a lot of more scope to be done at EU level. And I think building also on the last comment, I think that there's also really a reason to look at more permanent structures at Commission level to look at health workforce, because indeed this project-based, and I think there have been very good projects. We were involved in joint action and CPN, etc. But it does always, it's kind of an ad hoc and closed sort of finite solution. So I do think that especially in terms of data collection, and we address the issues that political cycles, look at short-term priorities, it's necessary to at EU level to have a more long-term outlook and more long-term structures to make sure that we can also address these topics, which indeed don't concern a horizon of 1 or 2 years, but 10, 20, 30 years.
Yeah, totally agree, of course, yeah.
But if I may, can I tell you, of course, I am very happy with this question. Absolutely, it's crystal clear. Please, I don't know, I have no chance to show you, but yes, you have no chance to see it, maybe.
Partly.
Because, partly, yes, because of, here you can see that in labor market, health sector is growing much more compared to in blue, those sectors like mining, agriculture, and so on. Labor market in health sector in Europe is growing every year despite of crisis. But when you are speaking about the labor market and about possibilities, how many times European Commission is discussing issues related to agriculture, fishery, and so on, you can see big disproportion. Ministers of Agriculture gathering in Brussels 12 times per year. Ministers of Social Affairs 4 times, not more. Ministers of Health 2 times per year. Why? Because treaty do not allow to discuss those issues in this, and it is absolutely, for me, crystal clear that we need to think about pan-European level, speaking about our possibilities to improve, to amend Lisbon treaties with some shared competences, helping member states to achieve their results on the ground. Comitology method can really be used as useful instrument, facilitating member states to find common solutions when we are speaking about healthcare workforce shortages.
Yeah, absolutely. You're absolutely right. And this is also, I would like to move towards the closing of the Q&A session. Actually, because we are running sort of out of time. What you're saying now is also corresponds with what we talked about earlier this week. We've had the pleasure to meet you finally in person, Dr. Andriukaitis, earlier this week. And you said to me, like, this is the moment in time to get geared up with such an advocacy coalition, because so much is happening at European level that could change health competencies of the EU, and including those on the health workforce issues. So yeah, I'm really excited to be at this crossroads now.
Corinne, if I may, please keep in mind Conference on the Future of Europe, 9th of May. And all three speakers, President of the European Parliament, President of European Commission, and also Presidency country, President Emmanuel Macron, all those raise questions. Yes, it is time to convene new convention and to discuss about possibilities to improve and treaties and to see how can we act in more effective way. And health was on top of those all three speakers. It is very timely. Now, as never, is important to promote political leadership for stronger European Health Union, to champion European Health Union across all organizations, and with political leaders to advocate the necessity to strengthen treaties and to build genuine health and well-being union as one of unions within our European Union.
Yeah, next to the monetary union and
because we have a lot of union, but we do not
no
have
health union,
health and well-being union. And people ask, people demand is very strong, and people support in health is very high, much higher than to thinking about other issues.
Yeah, the health and well-being union. I like that. We will have to change Ursula von der Leyen's language here, though. But good point, a good suggestion. I'm going to close the panel discussion because we have a few more words from Aysel for the end of the session. I see that Sarada will have to leave us in a couple of minutes. Already, many thanks, Sarada, for being here. I would also like to say to the audience and those of you who are considering becoming a member of the coalition, if you have listened to Dr. Andriukaitis and his passionate plea for more European integration, and now is the time, please join us. Aysel will tell you now a little bit more about what it is that we will be doing and how you can join and what we would expect from you and what we can mean for you. Thank you. Aysel, the floor is yours.
Yes, thank you very much, Corinne. And wow, what an interesting panel that was to listen to as well. So indeed, while I wait for the slides to come up any second, and what I'll be doing to show you a couple of slides, also how to join this process, the call for action that Corinne has put just now, and also the slogan on the banner that you can see behind us, to join forces together. So indeed, on Pills of Health, to tell you more about Pills of Health. So who are we? To start with, to tell you who we are and how I showed some of the research that has been conducted so far, and I really wanted to introduce to you the core team at the moment. So Pills of Health Coalition is an alliance of EU-based organizations. In 2021, Wemos joined forces with Center for Health Policies and Services in Romania, a media education center in Serbia, Athena Institute, also in the Netherlands, to identify ways to address negative effects of excessive health worker migration. And in 2022, we're now started collaborating with researchers and experts and partners in Germany and then other EU countries as well. Moving forward, what we want to do is really to do joint advocacy and create a wider coalition to address this together. What we want to do that also with bringing the civil society groups, public health experts, human rights defenders, trade unions, academics, researchers, everybody who is committed to expanding access to universal public healthcare. This could be you, the audience, and we need your expertise, your knowledge, your ideas and networks to make this stronger advocacy and more successful. On the next slide, I wanted to tell you a bit more on our mission and vision. So indeed, what we envision is that all citizens have equal access to skilled, motivated, and supported health workers as part of their right to health and as part of the progress towards universal health coverage, things that we've discussed earlier in the panel as well. Our mission is that we aim to contribute to a more equitable, well-balanced geographic distribution of health workers across the union in the region. We do this by joint advocacy and stimulating debate between civil society, policymakers, and other relevant stakeholders on the development and implementation of EU-level tools and measures. On the next slide, I want to showcase sort of some of the, for strong advocacy, we need strong evidence. We've been working on a number of knowledge products. Some of the examples that to highlight are our country research reports, some of the highlights I shared with you earlier, more to come, also infographics, policy briefs and fact sheets that you will be able to find also on our website. Additionally to that, we wanted to make sure that there is so much more out there, so much more information, and a catalog of additional resources that have been developed and are available. For instance, plenty of articles from global newspapers on the subject, scientific journals that focus specifically also on the EU migration of healthcare workers. There are also a number of relevant reports from collaborators and allies as well, and other sort of types of publications that are relevant to the subject. I want to also use this opportunity to also call for action to share more knowledge. If you have more information or more publications or any sort of materials that you think are relevant and should be showcased and featured, please let us know. On the next slide, I just to highlight sort of what to expect from Pillars of Health Coalition should you join and be part of this. Our work is around evidence building, capacity building, and shared learning. So some of the things that we plan to conduct is technical meetings, well, among the members of the coalition, but also inviting those from the outside of the coalition to facilitate the shared learning and develop better understanding. Technical meetings can be on subjects such as how the EU works, EU health and law, inviting experts on the European integration to also share some of their thoughts. How do you integrate gender and gendered approach into research and advocacy and any other sort of health workforce mobility related subjects. But really, it's also depending on the coalition members and what their interests are and what their needs are also to learn about what. So it will also depend on the members and the subjects on that. And also, if as a coalition member, you want to do an advocacy in your country, we will be able to help you to contextualize specific objectives to achieve your goals in that context as well. And of course, lobby and advocacy is a very big element, and we will be working together to develop a joint advocacy strategy and a pathway for change. We will continue mapping relevant stakeholders across EU, disentangling the really complicated EU-level actors, their allies, constituents, and others that influence the policy development. And really together, what we aim is to create a political will to make change happen. So next slide shows you how to get involved. So this is a launch of Coalition and the website, and we're really happy to announce that our website is now live. You can find it on what you see on the screen, pillsofhealth.eu, and a small screenshot of what the front page looks like. And I invite you all to please visit. We're still going to be adding the resources in due time, but what we would like to invite you now and to join forces is to click on the Join Us button, have a look at in the form. And the form is just to let you know a little bit about yourself and your interests, so then for us to get in touch with you, to get to know each other and explore the synergies that we will have moving forward. And with that, on the next slide, it's just to say many thanks for listening and yeah, act now to be part of change. Thank you very much.
Yes, Aysel, thank you very much. Yeah, applause. Yeah, so to the audience and those of you in the audience who are considering becoming part of this movement, the fun is about to start. I mean, we've only kickstarted a bit of the action with some research, with reaching out to policymakers, decision makers, and but also to try and understand where the specific policy ask we can make happen. We'll need you for that, with your expertise, with your networks. So become part of this movement and sign up. I'm going to round off this event. A warm thank you to all the panelists. You've been excellent. It was really a pleasure to hear from you and also to see your exchanges between each other. I thank the audience for some of the, well, very good questions actually. And I would like to say have a nice weekend after this event, and see you later, hopefully. Be in touch later. Thank you.
Let's
Thank you.
campaign, let's join, and let's demand more solidarity in health. Let's
Absolutely.
promote health and well-being union.
Absolutely. Totally agree. Thank you, Dr. Andriukaitis. Thank you.
Bye-bye.
See you. We'll be in touch. Thank you,
See you.
audience. Bye.